Previously on Antibiotics in the News. Dr. Daniel Tan warned us that community-acquired pneumonia was more dangerous than it seemed. He also shared with us the core principles of antibiotic therapy. And now, Dr. Daniel Tan returns to talk about not all cough is pneumonia, efficacy of amoxicillin clavulanic acid in treating acute exacerbation of chronic obstructive pulmonary disease. In this edition of Antibiotics in the News.
Many of us have treated patients with common cold. They come to our clinic. Let me give you an example.
Case: 65-year-old patient with common cold has taken amoxicillin thrice daily for 4 to 5 days with comorbid conditions, specifically diabetes.
Let's ask a number of questions. Are you a smoker? Do you have features or symptoms of airway obstruction? If there is, or there are some of these features, dapat ang suspect natin, meron siyang COPD who happens to develop common cold. What does that mean? Then the next set of questions should be, do you have increased phlegm, increased purulence, increased shortness of breath? Because these are the three criteria used in the Antonison's assessment of acute exacerbation of COPD. We must look into the risk factors. If they're old enough, let's say more than 65, they have comorbid conditions, they have more than 4 exacerbations per year, and their lung functions were poor. When you have more and more of these criteria, we have to give stronger antibiotics. And the guideline says one of the better choices should be a beta-lactamase and beta-lactam and beta-lactamase inhibitor. Why do we want to give the stronger, better antibiotics? One, we want to choose the one that has a faster bacterial killing among the objectives. Number 2, we want to use the one that can, as short as possible time, completely eradicate the bacteria. But then if we were to choose a beta-lactam, which implies it works through a time-dependent manner in order to kill the microorganism, we must set the goals clear. We want to optimize the duration of the exposure of the bacteria to the antibiotic, and we want to give it at a shorter interval. Example, if we choose what the guideline says, one of the better choices is a co-amoxiclav. If I choose a 625 milligram, it should not be given twice a day. It should be given at a minimum 3 times a day, because you want to give each intake of the drug a higher serum level, high enough to be above the MIC, but the total added duration in the 24-hour period, it should be 40% or higher. And only at 3 times a day can achieve that. If your choice were a Comox-Club of a 1 gram twice a day, it should be no less than 1 gram twice a day, simply because when you add up to the time above the MIC, it will also hit a minimum of 40% or higher. It's the only way to assure us of a maximal bacterial eradication. And the advantage is convenience and a better compliance coming from the patient. So let me conclude. Not all patients presenting with cough is bacterial in origin. Number 2, the primary objective of the attending physician in the clinic is to exclude the presence of pneumonia. Because if it were, then we have to follow the guidelines for the treatment and or management of pneumonia. Number 3, ask the patient, are you a smoker? Do you have symptoms of airway obstruction? If the answer were yes, this patient has COPD, then you ask the next set of questions. You have increased phlegm, increased purulence, increased shortness of breath. If the answer are mostly yes, then the patient is not just a COPD with a cold. The patient has acute exacerbation of COPD. In that case, we may have to give an antibiotic that can also deal with the problems of probable drug resistance because of previous frequent intake of antibiotics. And finally, if the choice were to you and me, a co-amoxiclav, it has been proven even up to now after so many years, that it can still offer the benefit better than the usual traditional first-line drugs. At the end of the day, it's not about saving a patient's life. It's about actually doing that little part in the lives of our patient and say, we have done our best to make it easier. It's a wonderful thing.
And that has been Dr. Daniel Tan, sharing with us the best way to treat AECOPD and Coramoxiclav as a better treatment option than traditional first-line drugs. And this concludes our Antibiotics in the News series.